In this part of the Progressive Longevity Education series, I want to look at cancer through a longevity lens, not to replace guidelines and not to challenge the excellent work done by GPs and oncologists, but to zoom out and ask a slightly different question. Most of us are very good at treating cancer once it declares itself. What we're less good at is appreciating how long it's been developing before we ever see it, how profoundly timing, biology, and risk stratification can shape outcomes long before treatment decisions begin. This session isn't about abandoning established screening or introducing miracle tests. It's about using what we already know and understanding where emerging tools may eventually fit in. The core ideas we'll focus on are why cancer risk accumulates silently over decades, why outcomes are driven more when cancer is detected than how it's treated, and how a layered guideline-aligned approach to risk assessment and screening can complement, not undermine, primary care and specialist pathways. Nothing here is about bypassing GPs or rewriting guidelines. It's about adding context, improving timing, and having the right conversations earlier with patients. This slide makes a simple but critical point. Cancer is largely a disease of time. And we can see across most adult life, the incidence is relatively low and flat. Then, from midlife onwards, that risk accelerates quite sharply, often earlier than patients expect. And that doesn't mean cancer suddenly begins in the 60s. It means the biological processes have often been underway for many years, sometimes decades, by the time we've made the diagnosis. So this is why timing matters. If we rely solely on symptoms or age-based cutoffs, we're usually intercepting the disease late in its biological course. This slide explains why age-based risk curves look the way they do. Cancer typically begins with sporadic mutations and early cellular dysregulation, and that's followed by prolonged periods of silent clonal expansion. All that means is that during this phase, the patient feels completely well, and there are no symptoms and no routine way to detect what's brewing. By the time we reach clinical detection, symptoms, imaging, biopsy, we're up here, we're intercepting the disease late in its biological timeline. That gap between the initiation and detection is the central problem that longevity-oriented thinking tries to address. Now, this is SEER surveillance data from the US, and it puts the numbers behind the story. The risk doesn't suddenly appear in later life. It accumulates steadily over decades. What changes is when the disease crosses clinical threshold. Diagnosis usually occurs on the steep part of the curve, not because biology suddenly accelerates, but because the tumour burden has finally become visible. From a longevity perspective, screening isn't about finding more cancer. It's about finding cancer earlier in its natural history, when the outcomes are fundamentally different. So this iceberg problem illustrates the mismatch between the biology of cancer and the presentation of symptoms. And what we see above the waterline, the symptoms and diagnosis, represents only a small fraction of the disease process. But below that surface, genetic mutations, clonal expansion, and even early dissemination may already be underway while a person feels completely well. The absence of symptoms is reassuring psychologically, of course, but biologically it tells us very little. And this is the basic premise of cancer biology and progression. It begins with a DNA mutation. If that mutation confers a growth or survival advantage to the cell, it will undergo what's called clonal expansion and make many copies of itself. Over time, additional mutations accumulate, increasing heterogeneity and adaptability. You have many different cells able to evade our defenses. And by the time cancer is clinically apparent, we're no longer dealing with a single abnormal clone. We're dealing with an evolving population with variable behavior and risk profiles. And so this evolving process is usually slow, but over time it makes cancer increasingly difficult to treat. One of the most important distinctions in oncology is between locally contained and invasive disease. Virtually every staging system involves distinction between local or invasive disease because it's so important to prognosis and treatment options. A local tumour, even if it's large, can often be very manageable and in fact curable. So to state the obvious, once cancer metastasizes or spreads beyond its site of origin, that's when it's most dangerous. Once this occurs, it's systemic disease. The treatment complexity therefore increases, and the long-term outcomes and chance of cure change dramatically. And this is why detection matters, not because cancer is always aggressive, but because spread fundamentally alters what is biologically possible with treatment. In early or local disease, tumour burden is generally low. Surgery plus adjuvant therapy, chemo or radiation therapy, often preserves long-term survival. But in metastatic disease, the drugs and treatments may be similar, sometimes identical, but because the timing is different, the outcomes can be radically worse. Again, when we look across most solid cancers, once metastasis occurs, the treatment effectiveness drops drastically. Not because medicine has failed, but because biology has moved beyond the curative window. So clearly, timing more than treatment choice determines survival chance. The last concept here is tumour burden and complexity. Early cancer involves relatively few cells, fewer mutations and limited diversity, making eradication far more achievable. As the disease progresses, the cell numbers increase exponentially, and with that comes genetic diversity, therapeutic resistance, and immune escape. And by the time the disease is metastatic, we're no longer dealing with a discrete target. We're managing a very complex, evolving disease. Again, that's why early detection is so critical. A solid tumour becomes dangerous only when it acquires the ability to evade immune control, and establish disease at different sites. Once a cancer is metastatic, particularly for solid cancers, it's systemic by definition, and it's more difficult for our immune system or treatment methods to manage, let alone cure. And so here we begin to see the significant overlap between cancer biology and metabolic health. Cancer cells preferentially utilize glucose, even in the presence of oxygen. And this is a process called the Warburg effect, where glucose is used by cancer cells to support rapid growth and biomass accumulation. At a population level, obesity and metabolic dysfunction are consistently associated with increased risk across multiple cancers. Now, while metabolic health modifies risk, it certainly doesn't guarantee outcomes, but it is one of the few upstream levers we can influence long before disease declares itself, or even once it has. Obesity and insulin resistance are associated with increased cancer risk, not because they directly cause cancer, but because they alter the biological environment. Chronically elevated insulin levels and IGF-1 insulin growth factor 1 amplify signaling through PI3 kinase, AKT, and mTOR pathways. These are growth pathways, and they sustain low-grade inflammation and increase cell turnover. So this doesn't guarantee malignancy, but it creates a growth-permissive environment once mutations occur. The key point here is that risk is modifiable. Improving insulin sensitivity, reducing visceral fat, and lowering inflammation shifts baseline risk and may improve outcomes even if cancer does develop. This pathway is critical to the understanding of cancer biology. This was really brought on by the work of Lou Cantley and his team. It identified the protein kinase called PI3 kinase is a signaler and a strong regulator of cell growth and survival. Insulin and IGF-1 specifically activate this pathway and increase glucose uptake and anabolic drive. Tumor suppressors such as PTEN normally act as brakes on this pathway. In insulin-resistant states, that brake is chronically pressured, not causing cancer directly, but facilitating growth once malignant cells are already existing. So this biology underpins why PI3 kinase inhibition became a major therapeutic target and why systemic metabolic context matters alongside genetics. In terms of screening, this slide highlights a reality that's often underappreciated. Increasing the sensitivity of a test inevitably increases the number of false positives, which create anxiety, and increasing the specificity of a test inevitably increases the missed diseases. So this trade-off is simply mathematical, and there's no best screening test in isolation. Therefore, screening performance is inseparable from the likelihood of the condition in the first instance, or what we term pre-test probability. And rather than relying on a single test, screening performs best when tools are layered. Clinical risk comes first, so age, family history, metabolic health. Blood tests further refine that signal. Imaging localizes the risk, and then definitive testing is reserved for those likely to most benefit. This approach doesn't replace guidelines, it operationalizes them toward the individual in front of us. This is the thoughtful approach for early detection, balanced with the limitations of a health system that has to work rationally. Layering reduces harm while improving meaningful detection. This slide explains why risk stratification matters so much. In low prevalence populations, even good tests generate many false positive tests. Of course, that's very anxiety provoking. The positive predictive value is low, not because the test is bad, but because the disease is rare. In high-risk populations, the same test performs very differently. The true positives increase, false positives fall, and the screening becomes much more useful. This is Bayesian reality. Test performance is inseparable from the pre-test probability. This process of selection doesn't change the actual test, but it changes how useful the result is by being selective about who the test is applied to. So Australian screening guidelines are population-level recommendations, and they work extremely well for that purpose. What they don't do is personalise risk, and there are just too many factors to have to comprehend in doing so. Earlier discussion or selective earlier screening is not about rejecting guidelines. It's about recognising that cancer biology isn't going to wait for calendar ages, and the risk is not evenly distributed in our society. At PSM, we do not replace guidelines. We use risk context to have balanced discussions and help GPs and patients decide when earlier investigations make sense and when they don't. Colorectal cancer is a fantastic example and the clearest example of why screening works. This is not a sudden disease. It usually progresses very slowly from normal mucosa to an adenomatous polyp to cancer over many years. The adenomatous polyp is precancerous. And so this is the critical point. The precancerous stage is usually visible and removable. We can actually manage this. And when polyps are removed, cancer never develops. So that's actual true prevention, not just screening. And this is why colonoscopy is uniquely powerful and why earlier screening can dramatically reduce lifetime risk in the right people. There were issues with prostate cancer screening historically because it relied on a single number. PSA alone cannot distinguish indolent from clinically significant disease. And modern approaches use other technologies, trends, density, fractions, and MRI to answer a simple question. Is this cancer likely to harm this patient? Not just does this patient have cancer? So screening today is more contextualized and considers the risk stratification rather than just reflexive biopsies for each particular cancer. A newer technology is emerging called the liquid biopsy. This is just a blood test that works by detecting fragments of tumor DNA that is shed into the bloodstream. These fragments carry mutation patterns, methylation signatures, or fragment characteristics that suggest malignancy. But sensitivity varies widely in terms of cancer type and stage, and a negative result does not rule out cancer, especially for small, localized, or slow-growing tumors. And that's why liquid biopsy should be understood as an adjunct and not a clearance test. Imaging and blood-based tests answer different questions. Imaging finds structure, it shows where a lesion is and how big it is. Liquid biopsy detects signal. It tells us if something is biologically abnormal in the background, and neither replaces the other. Used together, they can improve detection while reducing unnecessary downstream testing. That's the direction modern screening is heading. Complementary, layered tools, not a single test solution. And for those who are considering whole-body MRI, that can identify cancers as well, but needs to be taken fully into context with its limitations. So over the last decade, we've moved toward multi-analyte assays integrated with DNA, methylation, and protein markers, but imaging has also quietly improved in its resolution and protocol design. It's how we use these tools that counts. If we're seeing the translation of evidence and integration of these technologies, we want to make better decisions for patients. So moving forward, what's likely to change the fastest is not what we screen with, but how often and who we screen, moving towards surveillance intervals that adapt to risk rather than fixed age cutoffs. Immunotherapy transformed oncology by demonstrating that immune cells can eradicate cancer, our immune cells. And this was first clearly proven in melanoma, historically one of the most treatment-resistant cancers. Early checkpoint inhibitors, which are fairly complicated medications, were produced, and these induced durable and sometimes complete responses in subsets of patients. This fundamentally changed oncology, but it also taught us something sobering. Just like the rest of oncology and the armory of tools that are out there, immunotherapy still works best when tumor burden is low. Immune escape is therefore limited and clonal diversity is constrained. Even our most advanced therapies are biologically constrained, and biology consistently favors early disease. At the base are the fundamentals: smoking avoidance, metabolic health, insulin control. On top of that, layered screening applied sensibly and stacked, trying to find things earlier in select individuals. But the real goal is detecting disease when tumor burden is the lowest and the treatment options are therefore the most effective. Early detection is the single most important way to improve prognosis in cancer by allowing access to early treatment. So what do we actually do at PSM in regards to cancer screening? We begin with a structured assessment of age, family history, metabolic health, and lifestyle factors. We contextualize this and establish baseline metabolic and functional data. Screening referrals occur with the existing Australian system guidelines, coordinated with the patient's GP and relevant specialists. The education here remains central because informed patients make better, calmer decisions. We provide the right screening advice to minimize either false positives or false negatives. This content is provided for general educational purposes only. It is not medical advice, does not replace consultation with a patient's own doctor, and should not be used to make individual health decisions. Cancer risk assessment, screening, investigation, and treatment decisions depend on a personal medical history, family history, symptoms, and individual risk factors, and should always be discussed with a qualified medical practitioner. Nothing in this presentation is intended to bypass or replace the role of general practitioners, oncologists, or established screening programs. No patient-doctor relationship is created by viewing this content. If a patient has symptoms or concerns or abnormal results, they should seek prompt assessment from their GP or treating specialist.